2, 1, now. All right, and we are live. Hello, everybody. It's Dr. Alex Earl, and it's Hump Day with Dr. Alex Earl. This is the time I get to spend with you guys and answer all your plastic surgery questions. And you know it's coming from a good source because I am an Ivy League educated, Duke trained, double board certified plastic surgeon. All right, and today we're here at Pure Plastic Surgery, and we are continuing with the theme of the month, which is breast, right? Breast procedures. And today we are going to be discussing a very common combination, which is the breast lift with implant, okay? So that's something that actually we do quite commonly here at Pure. All of the surgeons here do that combination. So myself, Dr. Vidal, and Dr. Wiggriff. However, there are some surgeons out there that don't like to combine it, and I'll go over that and I'll tell you why. But I think if you have the right training and the right experience, it is something that you can definitely kind of put together. And of course, you do have to talk to your patients and make sure that they understand all the pros and the cons about combining these procedures, all right, and the possible need for any potential touch-ups or refinements in the future, okay? So let's talk about the breast lift with the implant. And so when we talk about a breast lift with implant, or before we get into that, we gotta first think about, well, who actually needs a breast lift in the first place, right? So which are the patients that are going to qualify for this procedure, all right? So because of course not everyone needs a breast lift, but there are many patients that do, especially those that have, undergone pregnancy, especially multiple pregnancies, breastfeeding, and of course those that have undergone weight loss, especially, large amounts of weight loss or massive weight loss, okay? So how do we know if you need a lift in the first place? So there is some criteria, and this all depends on what we call the degree of breastosis, or the degree of droopiness to the breast, okay? And that is measured by comparing the breast to what's called the inframammary fold, or the IMF. So the IMF is the fold underneath the breast. It's essentially what separates the breast from that kind of like upper chest or upper abdomen, lower chest, upper abdomen region, right? So that crease right underneath the breast. So that is the inframammary fold. This tends to be fairly well defined in most people. There are some people where it's not that greatly defined, but in most people it's very well defined. And so the degree of ptosis or breast droopiness depends on where the breast sits in relation to the inframammary fold. All right? So if the entire breast is above the inframammary fold, that means you have no droopiness, right? No breastosis. And so that is no breastosis, 0. All right? Which means then that you don't need a lift at all. You can just have your breast augmentation, straight up breast augmentation. All right? Now, if the breast starts to kind of go below the inframammary fold, but the nipple position is at the level of the inframammary fold, that's what we call a grade 1 ptosis, which means basically it's not too bad. It's a very mild ptosis. And in those cases, you may still require a lift, but it would be a minor lift and typically what we call a donut or circumareolar type of lift. Here, we're, by definition, we're only lifting about anywhere between 1 to 2 centimeters. Sometimes you can push it a little bit, maybe get to 3, though I don't really recommend that. But if you just need about 1 or 2 centimeters, then you can do that donut type lift, okay? That's really the only time where I would recommend doing this. Where you just need a very small amount of lift, okay? Sometimes if the nipple position is at the level of the inframammary fold, but it's really just because there's a lack of fullness to the breast. Sometimes we can do it just with the breast augmentation because the implant itself might be able to give you that 1 centimeter of lift if we're using a large enough implant, okay? So that's where really it's a judgment call by the surgeon in that sense, all right? Next is your grade 2 ptosis or droopiness, and that's where the nipple position is below the inframammary fold. So now we're below the inframammary fold, but it is not the lowest point of the breast. Okay, so it's below the inframammary fold, but not the lowest point of the breast. So for these patients, you're of course you're only going to need a lift. Sometimes you can do what's called a vertical or lollipop type lift. That's the one where it goes around the areola and then there's a vertical line down towards the inframammary fold. That's the kind of looks like a lollipop, which is why it's called that. The donut is just all the way around the areola. Okay, and so for a grade 2 ptosis, you'll need a vertical lift, or if it's a little bit of a kind of a moderate kind of grade 2 ptosis, you may still need that anchor type pattern. Certainly for any grade 3 ptosis where the breast is sitting below the inframammary fold and the nipple is the lowest point of the breast, that's what's called a grade 3 ptosis. For all of these patients, 100%, you're going to need an anchor type pattern. Okay, like that's it. There's no other choice, unfortunately. So if the breast sits below the inframammary fold and the nipple position is the lowest point of the breast, you're going to need an anchor type pattern for your lift, and that's the one that kind of looks like that. Okay, looks like an anchor. Whoa, echo. All right, and that's the anchor type pattern there. Okay. All right, and then last, this one's a little bit more confusing. This actually typically happens sometimes if you had a breast procedure or a breast implant in the past and that implant then bottoms out. That's what we call pseudotosis. When you have pseudotosis, the nipple position may be at or above the level of the IMF, but there's a lot of breast tissue below the IMF. Okay, and so you have to start, you gotta shorten that tissue, and even though the nipple position is not bad, a lot of times in order to fix a pseudotosis, we still have to do the anchor type pattern. Okay, because we have to shorten the distance of below the inframammary fold. All right. So obviously it's not super simple. That's why we go through many years of education and training and experience in order to come up with the best plan for each particular patient. And of course, we need your photos, we need to take your measurements, we need to also kind of combine that with your kind of end goals and desires to come up with what's going to be the best treatment plan for you. But certainly we can combine any of these breast lift patterns with an implant, all right? So that becomes the next decision. Well, how do you know whether I need an implant or not, right? Well, so here's how we determine whether you need a breast lift. So the next decision is, well, how do I know I need an implant? So that's going to depend on also several factors. One of them is going to be, that you lose a lot of volume to the breast. So sometimes after breastfeeding, especially breastfeeding multiple babies, you could potentially lose a lot of volume in the breast and have what's called like an empty breast. And also when you do or lose a lot of weight, when you have massive weight loss, which can be done either through diet and exercise or the bariatric surgery or with the injectables like Ozempic and Mounjaro. If you lose a large amount of weight, you are going to lose a lot of the breast tissue and fat, which means that the breast will then become deflated, and therefore you have to add back some volume to the breast, all right? So if you have pretty much kind of a deflated breast, or it could also be about looks or desires, right? You just simply want more volume, that could also be another reason why you want to add an implant, okay? And certainly it can all be done at the same time, but you got to keep in mind that you're now kind of, putting two forces kind of against each other, right? On the breast lift, you're kind of reducing the amount of skin, and sometimes you're reducing the amount of breast tissue, and then with the implant, you're by definition adding volume. So these two forces want to kind of fight against each other, which is why it's a little bit of a tricky surgery, and you really want to go to someone who has a lot of experience with this procedure. The other thing you want to be careful with is that when you do add an implant, the risk of certain things goes up, right? When you're doing a breast lift, for example, with a vertical, more with like an anchor type pattern really, there is a small but real risk of what's called nipple necrosis or nipple dying, okay? Nipple basically turns black and falls off. Not a good thing, very, very bad. If you go to experienced hand, this risk is very low, typically in the 1% range. If you go to someone who doesn't know what they're doing, this risk can be much, much higher. So please choose your surgeon carefully. And the risk for this does go up if you add an implant, and that's when you really want to go to someone who knows what they're doing, okay? Because you wanna basically try to minimize that risk as much as possible. All right. But what does an implant do for you? Of course, it's going to increase your overall volume, which is great. It's certainly going to give you some more volume in that upper pole of the breast. All right. And also it will kind of improve the cleavage area of the breast as well. All right. Now, what are some of the downsides of the implant? Well, if you're someone who has a little bit of a large breast and you're looking for a lift but also a reduction, you're of course going to not be able to do as much of a reduction if you're adding an implant, right? By definition, an implant has a certain amount of volume, right? Well, this happens to be a very large implant, and you would probably almost never combine this with a breast lift. But look at all the volume that's in there, right? Even a smaller implant is going to have a certain amount of volume, which means there's less amount of reduction that you can do to the breast, all right? So typically, if you're coming in for a breast lift with a breast reduction, you're not going to add an implant. And for those patients that you have enough of your own breast tissue, then that tissue can be used and rearranged to give you some more fullness to the upper pole of the breast. Okay? All right. So that's about it in a nutshell. And I'm happy to answer any questions regarding this or any plastic surgery questions that you may have.
We have a lot of questions, Doc. First one, hi, Dr. Earl. Can you donate the skin from your skin removal tummy tuck surgery?
Can you donate it? That's a very interesting question. And as far as I know, the answer is no. At least not in its kind of full form, right? So the skin is very what we call antigenic. It means it has a lot of your very personalized factors that are due to your genetics. And therefore, you can't really, say, for example, do a skin graft from one person to the next unless they are identical twins. And so say if you had a burn and I took, and I did a skin graft from my skin and wanted to donate to you, you would reject my skin, okay? Because we don't have the same genes and your body would reject it and that skin would fall off. So it's typically not something you can really donate in that sense. Now, having said that, there are companies that create what's called cadaveric skin. So they do take skin from people that have passed away, okay? And it has to go through a certain process. They take the skin and they pass it through a process where they're actually removing all the cells that are in the skin and they're keeping only the matrix that kind of the skin is composed of. And then that can be used for surgery, like a what's called a biological mesh. Okay, so a little bit of a long answer there, but I just wanted to explain all that. But just think of it in this term. So you can't really donate your skin to someone else because it'll be rejected in the same way like a kidney may be rejected or liver may be rejected unless they're on immunosuppressive medications.
About the topic,
Yes.
what if your breasts are at level 3 and you don't want an implant?
And you don't want an implant? So that's certainly a possibility if you have a certain amount of volume to your breast, okay? If you have kind of like that completely empty breast, it's probably not going to look great and you want to be able to add some volume to that. And I think the best way to do that is with an implant. But you can certainly have a grade 3 ptosis and still have some of your own kind of natural breast tissue, some degree of volume, and therefore we can use that breast tissue and that volume and rearrange it such that when we do that anchor type pattern, we can then kind of push your tissue up to give you more fullness in that upper pole and to give you some more of that cleavage. So yes, certainly that is something that can be done.
Different questions, but the same answer, I guess.
Okay.
Did Dr. Earl are using the new thing named internal bra implant? And do you use Galaflex to different people?
Yeah, so those are they are actually related questions, right? So the internal bra does refer to a mesh. There's different types of meshes out there. The ones that we typically use are what are called biologic meshes. So that means that these are meshes that eventually your body will eventually kind of resorb or incorporate, okay? And one of the most common ones that we use is called Galaflex. So do I use the Galaflex? Yes, I do. Do I use it routinely for absolutely everybody? No, and I don't think that's necessary. I think honestly out there's an overkill in terms of how much of this internal bra or Galaflex is being used. I think these meshes are very, very expensive because of that process that I was talking about before and creating them. And I think for most patients, they're not necessary. Especially if you're what we call a primary patient, meaning this is your first procedure, right? So this is your first breast dog or this is your first breast lift with implant. I don't think that internal bra or mesh is necessary. You're just paying for something that you wouldn't need in the first place. However, for these patients, remember I kind of mentioned these ones with pseudotosis are typically patients that have had a procedure in the past and they bottomed out. Well, yeah, if you have bottomed out before because from a procedure in the past, that's when these meshes do come in very, very handy. And I do recommend the Galaflex or the internal bra for patients that are now undergoing a secondary procedure. Either a revision type procedure or a reconstruction type procedure.
Okay, I have an anchor and now my nipple is too high.
Yeah, that's unfortunate. And again, that has to do also with the experience of the surgeon, to be honest. I never try to bash on anybody, but if you have an anchor incision and your nipple's too high, it means either that the surgeon messed up when they did their measurements, or and that's if it's too high from the very beginning, like from day one, nipples too high, surgeon messed up. I'm sorry to say it, bottom line, they messed it up. Or if say day one, everything was looking great, 3 months, things were looking still okay, and then at 6 months, all of a sudden, it seems like the nipple went too high. Typically, that means that the implant bottomed out. So the implant that's supposed to be kind of here, the implant fell down and that pushes the nipple up, and so now the nipple looks too high and the implant is sitting low, and sometimes that can be a cause for the nipple appearing too high if you have a bottomed out implant. So what's the fix? Well, the fix is obviously you can't directly pull the nipple down, okay, without causing an unsightly scar on the top of the breast. But what you can do is reduce this distance here. So the distance from the nipple to the inframammary fold is too long. Typically when you have a nipple that's too high, it means that the distance between the nipple and the inframammary fold is too long. And so the way to fix it is to shorten that distance. So you'll definitely need to redo your anchor type pattern, shorten up that distance, and sometimes you gotta reestablish the inframammary fold and place the implant in its proper position. And that's when potentially a mesh or internal bra may be helpful to make sure that implant stays in its proper position.
How do you feel about removing capsule around all implants when placing new ones?
I don't think that's always necessary. If you have a capsular contracture or if you have a thickened or calcified capsule, then yes, then it's a good idea to go ahead and remove the entire capsule. But most capsules are nice, thin, soft, no calcifications, no issues, in which case, removing a capsule can only bring you more problems and more complications, and it's not worth doing.
Can't wait to see you guys for my breast in 6 months.
6 months, all right, we're gonna be here anxiously waiting for you.
Question, what about adding fat to the breast?
Right, so that question actually comes up quite often, and so there's 2 ways to add volume to the breast that basically that we do today, right? One is with the implant and one is with fat transfer. And so there's certainly a lot of advantages and disadvantages to each, and also surgeon preferences. I myself personally, I don't like doing fat transfer to the breast, okay? I think the results are not great. And it could potentially lead to some issues for the patient in the future. Why is that? First of all, the breast itself does not have a very robust blood supply, which is very different than say the buttock and the buttock. We do a lot of fat transfer to the buttock here, a lot of BBLs. But the breast has the blood supply to the breast is not as robust, which means that it's tougher for the fat to take, which means that you can transfer less fat, a lot less fat, and you run a higher risk of fat necrosis or fat cysts. Okay, so whereas say in the buttock you can put even up to 2,000 cc's per side, in the breast the most you'll be able to put is maybe, I don't know, 300 cc's would probably be the most. The average is somewhere around 200 or so cc's, which means you can only give so much volume, right? Implants go, they go anywhere from 200 to 400 to 600 to the max, which is 800. You can add a lot more volume with an implant than you can with fat transfer. That's number one. Number two, when you do fat transfer to the breast, you can add a modest amount of volume, but you can't alter the shape of the breast, right? The breast shape is not going to change at all. So it's going to be the same breast, just with a little bit more volume. Obviously, with an implant, you can actually alter the shape of the breast, and you can give more of that nice, rounded, perky look. And then three, like I said, when you do fat transfer to the breast, there's a risk of fat necrosis and fatty cysts, which could then become something that is tougher to do the surveillance of when you're doing your surveillance for potential for breast cancer in the future. So it can be kind of like confused in your mammograms or your ultrasound, and then it may lead to unnecessary biopsies and things like that. Okay, so for all those reasons, I personally don't like to do fat transfer to the breast. That's not to say that there aren't surgeons out there that do it. I think you have to be aware of all the pros and cons. And if you wanted to do it here at Pure Plastic Surgery, certainly Dr. Vidal is one of the surgeons here that is able to do fat transfer to the breast.
Okay, I hope you do my BBL next year.
All right.
Oh, not me.
Certainly, yeah, we're here for you. And if you want to, or whenever you're ready, you can obviously always call us at 305-230-4326, or just go to our website and hit that virtual consultation button, or the one that says start your journey. So when you're ready to start your journey, go to our website and hit the button that says start your journey, and we'll be able to help you every single step of the way.
I have an implant, 475 cc's.
Okay.
Can I go down to 125?
Oof, 125 is quite a bit. And honestly, for an implant that small, it's probably not even worth it. I would rather just remove the implants, the original implant altogether. But you can. So let me take just in general, can you downsize implants? Yes, you certainly can. However, when you downsize an implant or remove an implant, you're then very likely going to require a lift, okay? Because you're going to be losing a lot of that volume. And 475 cc's, is quite a bit of volume. So if you were to take that out, the breast will then become fairly kind of more droopy. And so you're going to want a lift to kind of then put it back up into place, all right? So keep that in mind. When you're downsizing implants, you got to do two things. First of all, you got to tighten up the pocket where the implant lives inside, right? So now you have a larger pocket to accommodate a larger implant, and now you're switching that to a smaller implant. So you got to tighten up the pocket around that implant. So then you got to see what you have to do with the breast skin and the breast tissue, because a lot of times you have to tighten that up as well, which is what you do with the lift.
Dr. Earl, do you still do Avali treatment for cellulite? I love to do it with you. And another person asked if you can do it Avali after a BBL.
Yeah, so certainly we're still doing the Avali for sure. I think it's a great solution for cellulite. It's the only solution that I've seen in my career that actually works. It works excellent. It'll improve the area anywhere from 80 to 100%, and it's a one-time deal, right? You come in, you get your Avali device, and that specific cellulite dimple that was treated only needs to be treated once, and you're done. It'll never come back in that particular spot ever again. All right. So yeah, I'm certainly doing the Avali, and it's also being done by the person we call the Avali Queen. That's Jenny, our nurse practitioner. So Jenny does most of the Avali out here in the clinic setting. I'll do it in the OR, typically combined with some procedure that we're doing at that time. But yes, we're certainly doing that. So if you're interested in getting rid of your cellulite, really there's only one solution And honestly, we're basically the top Avily clinic in all.
Platinum members.
Yes, we're the platinum members, and we're the top clinic in probably all the southeast for sure. I think pretty much all the East Coast really, but we're number one here.
Okay. What are the signs when your body rejects a saline or silicone implant?
All right, so first of all, let's talk about that term reject, okay? Because there's a lot of things that people call reject, which is not really a true rejection, okay? When I think of the word reject, at least in medical terms, what I think about is like, the body is attacking something, right? Like, for example, an organ, right? If you have a transplant, if you're not immunosuppressed, or even if you are, sometimes the body recognizes it as something that's not part of itself, and then it actually attacks it, and it rejects that organ, okay? Now with an implant, it's a bit different because the implant is inert, right? There's no antigens here, all right? It's made of silicone, and silicone is inert, okay? Your body doesn't necessarily, attack it, okay? But it is a foreign body, okay? And so there are a few things that can happen. One is maybe you get an infection. So some people call that a rejection. But it's not really that your body actually rejected the implant, it's that you developed an infection that was around the implant, and therefore in order to treat the infection, the implant needed to be removed. Okay? That's one example. The second example is what we call capsular contracture. So your body naturally forms a wall around the implant, but sometimes that wall can become thickened, okay, and hardened, and it can start to really crunch the implant, become very, very tight, and distort the implant. All right, again, not a true rejection, but that's what's called capsular contracture. And if that develops to what's called a more severe form, a grade 3 or 4, then that's going to require surgery to go back and remove that entire capsule, and then and then do an implant exchange or replace the implant. Okay, so that's what most people call a rejection. But it's not a true rejection in the sense that your body is actually attacking the implant like it would, an organ or something like that.
Okay, we have tons of questions, Doug, and we're on time. But this one, is it best to go under the arm for an implant?
No.
Subaxillary, I guess.
I don't like that approach at all, honestly. I don't like that approach. It's, well, first of all, it's a bit of a blind approach. Number two, you're not really releasing I don't think you're releasing the pectoralis muscle sufficiently. It turns to lead to implant malposition and implants that are sitting too high. So I don't like that approach. I don't use it at all. I think actually the best approach, the one with the least complications and the one where you have the best long-term results and the least risk for implant malposition, is the inframammary approach. And I know a lot of people are like, oh, doc, but that incision down there, if you go to someone that has a lot of experience, you can use that approach and use a very tiny incision. So my incisions for a straight breast augmentation are 3 centimeters or less. Very, very tiny incision, hidden in that inframammary fold. If you're standing, if you're a swimsuit, or if you're in a low cut, dress or clothing, it's not visible at all, okay? And that is the best approach because that is the one that's demonstrated to have the least risk of infection, the lowest risk of infection, the lowest risk of any implant malposition, the lowest risk of capsular contracture. So overall, it's basically the approach with the lowest risk.
Last one.
Okay.
A classic one. Can you do a BBL and implant breast reduction at the same time?
So I'm gonna say for the most part, no. Okay. Because here, especially here in Florida, I mean, every state is a little bit different, every country is a little bit different. But in Florida, if you're doing the surgery in an outpatient surgery setting, such as the one we have here at Pure, we're limited by the Florida Department of Health as to how much fat we can remove via liposuction, and that limit is only 1 liter. So if I'm doing your breast surgery, all of a sudden I go from 4 liters to 1 liter. All I can remove is 1 liter, which is not going to be enough for your liposculpture 360. You're not going to get the results you want there. and it's not going to be enough for what we want to transfer to the buttock and hips. I can only divide that in half and do 500 and 500. So basically, you're not going to be happy with the BBL portion of the procedure. So it's just not worth doing it that way. It's best to separate it out. So do your breast surgery first or second, really, whatever you want to do. But you want to do your breast surgery, and then 3 to 4 months later, you can do your lipo 360 and your BBL.
Well, one more. Sorry. Is a good one.
The bonus question.
Yes,
bonus
sir.
Round. Here we go.
Because 3 times, 3 different persons. So if you had an hernia repaired, can you still have a tummy tuck?
Yeah, and a lot of times if it's not like a super, like I would say, it's like a very large hernia. Like if you have a small hernia, especially like a small belly button hernia or small ventral hernia. Ventral hernias are the ones that are along this line here. If you have a small hernia, it can be done. It can be fixed at the time of the tummy tuck. You don't necessarily need 2 separate procedures. So any small hernia around the belly button, any small ventral hernia, you just kind of let us know, because we can do an evaluation and we can determine if it's something that's going to be okay and easily done at the time of your tummy tuck. And that way you don't have to do 2 different procedures. You can just get it all fixed at once. Now, of course, if it's a large hernia, right, something that's kind of very, very big, then that's going to require potentially like a mesh or something like that. Then yes, it's best to have that fixed first. But then you still qualify, all right. Once that hernia is fixed and everything is healed, you can still get a tummy tuck after.
Oh.
Okay. All right. Okay, everybody. So I hope that kind of explains this, okay? Now you know who needs a lift and who doesn't, and most likely what kind of lift you're going to need. And then you can also should be able to discuss whether you want an implant or not at that time, okay? But of course, if you have any questions, please write to us in the comments, shoot us a DM. We're always happy to answer, all right? And don't forget that all of our educational videos and Hump Day Lives are on our YouTube channel. So if you feel like you need more information, just go to our YouTube, go to Pure Plastic Surgery on YouTube. You're gonna have essentially a whole library, a wealth of information, if you will, for any subject regarding, for any subject within plastic surgery. So I highly encourage you to go there as well.
200 likes at the moment.
Oh, and
200.
200? Yeah, we have 200 educational lives on there. And we discuss pretty much any topic and any question that you can think of. All right? All right, and then just before you go, I want to give you guys a little teaser, a little kind of sneak peek, but we're going to have a very nice promotion, right? A flash sale next week. But guess what? You're only going to hear about it through our social media channels. So make sure you're tuned to all our social media channels next week so you can hear about our flash sale for next week. All right? Okay, everybody. I look forward to seeing you then.